All right. Anyway, so I don't want to take credit for the work that Sean, one of our residents, has done with a couple of our postdocs, but this is the system that we have used. You guys already heard Dr. Rock. This is a 70-year-old man with history of seizures, memory loss, left upper extremity weakness. This is the preoperative MRI. It's just going to be a couple of minutes. You can actually see a very deep posterior thalamic lesion. It's a very, very daunting, actually, type of tumors that, you know, as brain tumor surgeons, we encounter from time to time. This is the actual patient in the operating room. I since then have learned you can actually do a very small cortisectomy. That's actually, we can even do it smaller than that. Sean has been doing a wonderful work actually identifying the corticospinal tracts to try to make dissections through that, getting in. This is the actual system that I've been using. It's just a Greenberg retractor to actually hold this in place. That is the actual holder. And I think that we're going to get into, we use the navigation system. This is the intraoperative suite scan. You can actually see going after the lesion at this point with another one of our residents right here using the navigation system to just go ahead and dissect the tract. This is under the microscope where we do the dissection. That's just all the amount of tissue. What you saw is what we ended up taking as we did the dissection. And other than that, the brain is separated, and you can actually do this. I'm actually going under the microscope to go and do the actual tumor resection in this case. When we're doing the tumor resection, everything, obviously, we're using a combination of the navigation system as well as the microscope, going back and forth with the small sort of suction device, a little bit of bipolar. I like to use the bipolar that we use mostly in the pituitary cases as well, which is a long bipolar, so that way we can actually go deep. The tumor is done. I go ahead and remove the device very carefully. As you can imagine, you can actually see it's a very flexible arm, which is the Greenberg in this case. We remove it, and you can actually see the cortisectomy just falls back into place. Sean is actually quantifying very scientifically with imaging, especially the flare navigation, whether or not there's any swelling on this, and that's the actual resection. It's not a complete resection. There was a little bit of tumor, but anybody who's done this tumor very deep in the thalamus recognize that these are very, very challenging lesions right here, and that's the actual device that we use. And I'm going to move the other two cases that I have right here. See if I can pull them for you. The next cases, so that was one of the cases, deep thalamic. I'm going to show once again with Sean and two of our postdocs in the laboratory. We're going to go in. This is a 41-year-old woman, memory problems, nausea, vomiting, headaches. So this is pointing into a hydrocephalic type of question. You can actually see the lesion right here, also going through the foramen of Monroe. Very challenging. Actually, I tried to go after this lesion first just with the pure endoscope, and it was very challenging. I called Steve. We ended up bringing the Vycor system through a very small cortisectomy right through Coker's Point on the right side, and you can actually see the lesion right here, right at the foramen of Monroe, and it was a colloid cyst. And we're going to do, you can actually see the venous system going into the venous angle right here, the choroid plexus. So we begin to do this just like any microsurgical dissection. Going with the endoscope, for me anyways, in my limited experience, has been very challenging actually. And I discussed this, Dr. George Jallo, who's one of our pediatric neurosurgeons, he's been using exactly the same device to do his cases, and he's a very experienced endoscopic surgeon, so it's been very, very challenging. So you can actually see the complete resection in this case of this lesion right at the actual foramen of Monroe through a very small. And Steve, what tube do we use? We use the smallest tube actually. And then at the end you can actually see a complete resection of this case actually. The next case, it was actually the very first case that I did with Steve, you know, over a year ago, when we had another patient. This is a 41-year-old man with history of AIDS, right-sided weakness. Workup show a lesion, very deep anterior thalamic. You can actually see right here into the insula, dominant hemisphere. Very challenging lesions to get into. I couldn't do an awake craniotomy. We needed to obtain tissue, so we ended up doing a supraorbital craniotomy, going through the left side, a supraciliary approach, right through the eyebrow. We came down with the surgical navigation. You can actually see the navigation system, same setup with the actual Greenberg retractor, and you can actually see the post-op. And this actually turned out to be a very challenging also type of lesion and infection actually. So we did also a very good thorough resection. So I think that the actual videos that Sean put together with the postdocs in the lab, they're pretty self-explanatory. It's really not complex. In my experience, it's been for me, what I'm interested in is deep brain lesions, and that's where I found it to be most useful. Most of the time when I put retractor system, there's a little bit of give and take, obviously, and putting the blades in there. Sometimes you end up pushing them or pulling them out. For me, it just makes really a very simple device that I can go in and push some of the times the corticospinal tracts, and actually it's allowed us to really approach these deep lesions. And now we're quantifying actually in a very systematic way what the actual edema, what is the damage you ended up potentially causing. That in my experience, once again, these patients done very well, but hopefully Sean will be producing a manuscript, a peer-reviewed manuscript pretty soon about that. Yep. So, thank you very much. I don't mean to, take your time. You have more important things to do, I'm sure. Thank you.
So much.
My pleasure. Thank you.
Well, you gotta come visit.
Oh.